Hello everyone, this is Dr. Karuna Kumar, consultant hematologist and bone marrow transplant physician. So today we will be discussing the most common problems faced by patients with ITP. ITP is an immune-mediated disease where our immune system targets the platelet counts, attacks them, and then clears them from leading to low platelet count. So whenever a patient comes to us with a low platelet count, the first step is exact diagnosis. Here we should try to find out the exact reason for low platelet. Normally we examine the patient and we do certain investigations where we'll rule out other disorders, and once ITP is confirmed, the next step is the platelet count decides the treatment. So if the patient has a platelet count above 30,000 and asymptomatic without any bleeding symptoms, then usually these patients need only observations. These patients do not need any treatment. Except when they are on blood thinners or if they need any surgery, no need to increase the platelet count in such situations. So those patients who need only observation, most of them panic just because of numbers. It takes time to accept that the low count is fine and to live with it. So these patients who go on observation can have low platelet count for years together. Sometimes the count may fall back to less than 30,000 and they can become symptomatic in future. That's why these patients should stay on follow maybe once in 3 months or once in 6 months, or they may have to monitor as advised by their treating hematologist. So those who have platelet count less than 30,000, usually we start treatment with corticosteroids. These are the standard first line medications in these patients. So there again, each patient responds differently. Few patients they respond to very low dose of corticosteroids and few patients may require higher dose of corticosteroids. So the problem with steroids is continuing the steroids for longer duration, months together without supervision leads to a lot of side effects. In fact, the ITP per se may not affect the patient much, but using steroids for longer term can lead to multiple side effects like obesity, weight gain, decreased bone density, diabetes, hypertension, etc. So when you are on steroids, always stay close follow-up with your physician, always discuss with your treating hematologist and reduce the steroid as soon as possible and discuss other treatment options. So once we start is corticosteroids like prednisolone, so we monitor patients weekly initially. Usually it takes at least a week or two for the platelet count to become normal or to increase. By the end of second week, if the platelet count normalizes, normally what we do, we tend to taper the corticosteroid, reduce the dose slowly and stop it by the end of 4 to 6 weeks. So often what happens, once we start reducing the steroid, usually the platelet counts tend to drop again. But again, important point here is if the count stays around above 50,000, it's okay to continue to taper and keep the dose of steroid as low as possible. So the point here is corticosteroids are excellent medicines if used for a short duration and as required. Suppose say you are not responding to steroids and your platelet have increased on high dose of steroid, but it's coming down again once the dose is reduced. Then what should you do? This is a situation where we think about second line treatment options, and there are many medications which can be considered as a second line option. I classify ITP medications into broadly two categories. One set is called immunosuppressive medications. The other category is the platelet stimulants. Normally immunosuppressive category are the ones which reduce the attack on the platelet count, thereby controlling the immune system and increasing the platelet count. Normally, for long-term purpose, these immunosuppressive medications are generally not considered safe because they suppress your immune system, and prolonged suppressing of your immune system can lead to infections and other problems. In few patients, there won't be much options left. In such cases, it's okay to use low-dose immunosuppression for prolonged times, but under supervision and monitoring as per your hematologist advice. The second category of medications are called thrombocytopenic agonists, basically which stimulate the platelet count, which increase the production of platelet count, thereby normalizing your platelets. There are two drugs under this category which are called eltromopag and romiplostim. When choosing a second line medications, nowadays these drugs are preferred because they do not suppress the immune system and they relatively have lesser side effects. Once we choose second line medications, most of the patients they ask us, doctor, how long should I take this medication? Should I take this medication lifelong? This is the most common question which we face in day-to-day practice. Normally ITP in adults usually follows a chronic relapsing pattern, whereas in children, 70 to 80% of the kids, usually eventually they get cured. So often in adults, they will require a medication to control the platelet count to keep it at a safer level, which can go for months and years together. But remember, every year on these medications, there is a 30% chance that your disease can go into remission and we can stop medication. Often patients here, they request for medications which can solve their problem at once, but unfortunately we do not have any medication which can cure ITP permanent. But there are few medications which can induce long remissions in ITP patients where we can stop using medications for a certain duration. A drug called Rituximab, it suppresses immune system and it can reset your immune system, which can lead to prolonged remission, sometimes for 2 to 3 years, where you may not require any medications. Usually Rituximab is used in a relapsed refractory setting where the patients are unable to use the second line medications and have side effects because of steroids. So patients who are fed up with using medications months and years together, sometimes they come to me for advice on splenectomy. This is a surgery where your spleen is removed to control the platelet count. This surgery used to be popular in olden times, which used to be a standard therapy for refractory ITP. But now with advent of these thrombopoietin agonists and second line medications, we are not considering splenectomy as a second line or even third line. We are using it as a last resort in few selected patients where nothing works. Spleen removal surgery can lead to certain bad infections and also a thrombotic risk in few patients. That's why this surgery to be advised selectively in few patients and to be decided by a hematologist. So few patients who worry about using medications for longer term and having this disease months and years together, I always advise them to adjust to the disease, and they have a platelet count above 50,000. I tell them to remain happy and focus on their day-to-day work instead of carrying the burden of worry in them. Often this simple step requires a mindset change which can lead to a happy lifestyle. So two things are important: having a safe count of 50,000 and using the medications as low as possible with the least side effects. Cost burden is a real issue in these patients who have to continue medications for months and years together and have to keep on visiting hospitals multiple times. Never try to target your count higher and by giving multiple medications and more doses. Instead, target a safe count of 50,000 and keeping the dose to the minimal level reduces the side effects and also reduces the cost. There are few patient support programs available. Please discuss with your hematologist which can additionally lighten your cost burden. So when ITP is diagnosed, initially you may have to come frequently for follow-ups, but later once your count is stabilized, you can do self-monitoring at your home and you can visit hospital once in 3 to 6 months. And also with time, once your disease responds, the dosage of medications may come down significantly again, which can reduce the cost over time. What if none of the medication works? So there are few patients who don't respond to any medications. In such cases, what we do is we try to combine different medications which the patient have not used or used in the past. Sometimes there can be a single unique combination which can work for the patient. This has to be done by the trial basis, which with patient under close follow-up. ITP commonly affects young women, and often these young women would be worried about pregnancy, whether they can conceive or not. Sometimes the disease itself manifests in pregnancy when they come to us. If a pregnant woman has a platelet count above 30,000 and no bleeding symptoms, initial months of pregnancy we can just observe the patient. Once they approach term, so we have to increase the count to keep at least 50 to 75,000 for delivery. There is limitation of medications which we can use in pregnancy. You need to discuss with your hematologist for appropriate medication which can be used to increase the platelet count while you are pregnant. Remember, even with ITP, you can become pregnant and safe delivery is possible. If you are married and have doubts about pregnancy, it's always good to have a counseling session with a treating hematologist and a gynecologist before you plan pregnancy. Almost every patient asks me about diet. Is there any special diet to increase the platelet count? ITP is an immune-mediated disease. It's not a nutritional deficiency. So often relying on special diet is not helpful in increasing platelet count. But going on a healthy diet definitely helps you reduce the side effects of steroids. I advise all my patients who are on steroids to cut down on sugar, sweet and dairy products and bakery items to reduce the side effects. I would suggest a meal which has high fiber content and vegetables along with high protein, especially while you are on steroids. Will I die because of ITP? This is the most common fear which every patient is worried about. The good news is the chance of an ITP patient dying because of severe bleed is very, very low. For most patients, the biggest challenge is not the risk of death, but it's the anxiety of living with a chronic disease. I hope this video is useful to all. Follow my channel for more exclusive content related to blood disorders. Thanks for watching.